This audio lecture is on the peripheral nerve disorders that your book talks about. So we have 12 pairs of cranial nerves that are considered the peripheral nerves within our body. And lucky for you guys, you just have a few that we're going to study here. So starting with trigeminal neuralgia, that is the fifth cranial nerve. If we had to summarize this trigeminal neuralgia in one word, what would it be? Pain, right? So that's a classic symptom. Abrupt onset of severe pain. It's usually unilateral, somewhere in the face, neck, forehead, cheek, nose, lips, gum area. Okay? These attacks are brief, lasting anywhere from seconds to minutes, but if you're the one that's having that pain, it doesn't seem brief. These patients can be in horrible pain. Some of the pathophys of what can cause this can be the herpes simplex virus. You'll see that kind of strung through all of these cranial nerve disorders as a cause. Other causes being elevated blood pressure, patients with MS, multiple sclerosis, and then patients that have shingles or masses in the brainstem. These can all trigger trigeminal neuralgia. I used to work with a nurse actually at KCC. She was my office mate. She had went in to get some dental work, and a couple days after the dental work developed the severe pain, and it would be these brief attacks. It would be sharp in nature, and it would affect the side of her cheek and gum area, and she would be working, and all of a sudden she would be reduced to tears because the pain was so bad, and that's what happened. So hers was triggered by some dental work she had done. So it can be a wide variety of things. And what they say is happening is there's a compression of that nerve, of that trigeminal nerve. And that's what is causing that significant pain. Some triggers that could cause pain in somebody with trigeminal neuralgia could be chewing, could be washing their face, brushing their teeth. It could just be hot or cold air that hits their face. Yawning could cause pain to happen in somebody with trigeminal neuralgia. Talking, touching their skin or tickling them, things of that nature. So you can imagine if you're the nurse coming in to take care of your patient or do an assessment on somebody with trigeminal neuralgia, are they going to want to be disturbed a lot? Are they going to be wanting you to touch their face a lot? Are they going to want to do a lot of talking? Probably none of those, right? Is it still important, though, that we assess them? Absolutely. Can we do that visually? Yes, we most definitely can. They can open their mouth for us. We can look inside their mouth. Why is it so important to look inside their mouth? Because they are probably going to eat improperly. They're going to probably neglect some hygiene practices because we just said that brushing their teeth is going to cause or trigger pain, potentially. You might see them withdraw from people, withdraw from social interactions because talking tends to trigger pain. They may sleep a lot to deal with pain. Even though this disease itself is benign, patients can withdraw enough that they actually think of suicide if this pain seems to overwhelm them and that they feel like there's no way out of this pain. So it is significant. It's going to affect a person differently from person to person, so that is important to note. Some treatments that we're going to do for these patients are drugs. Sometimes you'll hear anti-seizure drugs that they're put on because it is decreasing the firing of the neurons in that trigeminal area. So things like Tegretol, Triliptal, Dilantin, valproic acid, which is Depakote. Those are some drugs that are given to help them deal with this pain. Our goal is obviously pain relief for these patients and to try to encourage them to do good oral hygiene, that we're assessing their mouth to make sure they're not trapping food and things like that. Best time to assess these patients is when they have their pain meds on board, right? And that their pain is adequately controlled. That's going to be the best time to do our assessments. The book also talks about nerve blocking. This is a local anesthetic basically that lasts anywhere from 6 to 18 months depending on the patient. Book also talks about biofeedback, and it's kind of a way to train the brain. It uses the power of the mind to control your body by using electrical sensors that helps the patient receive information. Again, it tries to help the patient deal and overcome pain. There are surgeries listed in the book. You do not need to know every single surgery and exactly what that all entails. What I would like you to know, though, is that sometimes with those surgeries, it can affect the eye. So the corneal reflex can be impaired after surgery. So we need to protect that eye, and that might be with a patch. It might be with lubricating drops, and we need to examine the eyes regularly for any symptoms of signs and symptoms of infection or irritation. So nursing management-wise, we're going to obviously pain assessment and pain control. Monitoring their environment. You don't want the room to be too hot, too cold. Putting a fan in there is probably not the best idea to be blowing or getting drafts on their face. They're going to be very cautious about others doing their care in fear of them, in fear of that nurse or CNA, let's say, inadvertently causing them pain. Using a small, soft bristle toothbrush, warm mouthwash, like room temperature, those are going to be all important things. We said the best time for the patients or the nurse to help carry out hygiene activities or assessments is when their pain meds are going to be at their peak. We want to make sure their nutrition is good, so adding foods that are high protein, high calories, lukewarm room temperature, and frequent small meals. If they're not eating, they may need to have an NG to the unaffected side to help them get the nutrition they need, or maybe even some peripheral PPN. And then after surgery, you might have to encourage that patient to chew on the unaffected side, avoid hot drinks, check that oral cavity after meals, and then just make sure that they're doing meticulous mouth care. One thing I forgot to mention is when they're trying to diagnose somebody with trigeminal neuralgia, usually they'll do an MRI, basically because they're ruling out other causes of pain, such as they've got a mass, sinus mass, or cancer, or a brain lesion. So they're trying to rule that all out, and then bringing in their history and risk factors. Then they'll then they'll diagnose them with the trigeminal neuralgia. Some things new in this new edition of Lewis that they talk about for drug therapy that I didn't mention a few minutes ago was Elavil or amitriptyline, or Pamelor. Sometimes you hear those used in antidepressant. Again, same type of thought process that we talked about with the anti-seizure drugs. And then some alternative methods that are talked about in this edition also is acupuncture and yoga. We're in the society, in today's society basically, that there's a lot of other things than just meds that people use, right? So yoga and acupuncture are things that are talked about in this book that might be used with these patients. Moving on then to Bell's palsy. This is a seventh cranial nerve. It does just affect one side of the face only, and then I want you to think about how could we summarize Bell's palsy in a word or two? Facial paralysis, right? Again, usually one-sided. Again, the cause can be accompanied with a breakout of herpes simplex virus, and usually around the ear. So if you have a patient that's talking about, especially if they've had a history of this and a known history of herpes simplex virus, when they start to get pain around their ear or itching, then they need to let that physician know right away, because they're probably going to have an outbreak then of this Bell's palsy. The book also talks about susceptible groups for Bell's palsy being women in their third trimester of pregnancy, early postpartum, older adults, and people with diabetes or hypothyroidism. A lot of times, especially with the herpes simplex virus, the premise behind that is it's causing inflammation, edema, ischemia, and it demyelinates the nerve. So remember, our nerves have that hard, thick myelin sheath covering around it. So what's happening in especially with the herpes simplex is that is demyelinating. It's losing that protective sheath, and then it causes that inflammation, and in turn causes the pain and the facial paralysis. Some other etiologies, it talks about, this book talks about infectious causes such as some viruses, Epstein-Barr virus, influenza, mumps, rubella. You can read that there. So there are some other causes that are new actually to this edition that they talk about for Bell's palsy. So kind of a wide array of things that can cause it. This can be a rapid onset. Other things besides just the facial paralysis, patients might also have numbness of the face, tongue, and ear. They might have ringing in the ears. We call that what? Tinnitus, right? They might complain of headaches. They might have hearing issues with this. The classic sign, and I believe your book does show the picture of the lady, yes, on page 1439, where the eye, when closure is attempted, is not, the eyelid has an upward movement, okay, and you have an inability to close the eyelid on that affected side. So that's kind of the classic trademark, if you will, of Bell's palsy. Diagnostic studies, we're back to doing an MRI and CT basically to eliminate other causes. And again, then bringing forth other, history and symptoms, then they will diagnose them with Bell's palsy. Your book talks about doing blood tests also to diagnose infections. Again, we're just ruling out other things that might be happening. So sometimes this is a process of trying to figure out exactly what's going on. That can be frustrating for the patient because it can take time to actually figure out what's going on. Treatments, steroids. What's a common steroid we use? Corticosteroids like Salumedrol, right? If they're started immediately, we have the best results. If they're initiated before paralysis is complete, okay? Could we still treat them? If they come in after that paralysis begins, yes, will we have the best outcomes? Maybe not so much if we would have started them before that paralysis is complete. You might see them used in the past. We heard patients being put on antiviral drugs such as acyclovir or Valtrex, and the studies have shown that those are really not effective anymore in the management of Bell's palsy. So really we go to corticosteroids for treatment for these patients. They might have mild analgesics prescribed such as Motrin or Tylenol, using a heating pad, gentle massage, and then electrical stimulation of the nerve. And again, this can be something that can be very debilitating to the patient, even though it is a benign type of disease process. Patients tend to recover in 6 months, but while the patient is going through this, it can be very detrimental to them psychologically. Thinking back to, I talked about the corticosteroid being Salumedrol. When they go home, they'll be on the oral form, which is what? Prednisone, right? So again, it puts them at risk for infections. We have to be monitoring that. We have to be monitoring their eyes, and also right back to good nutrition, chewing on the unaffected side, watching to make sure they're not trapping food, etc. Then we go into Guillain-Barré syndrome, which we commonly hear about Guillain-Barré with what? We always hear it every year, right? And in the fall, when we get our flu shot, because it asks us if we've ever had a Guillain-Barré. This is ascending paralysis. Okay, so we have paralysis starting from the feet and moving its way up to the body. In Guillain-Barré, we're having the loss, again, of that myelin sheath that surrounds that nerve. It causes immune destruction can cause this. We have edema and inflammation follows. It is a cell-mediated immunologic reaction and usually preceded by viral or bacterial infection. Again, this goes right back to having immunization, such as the flu shot. That's why it's asked on our flu shot consent. Somebody with HIV, somebody who's recently had surgery, trauma, these are all things that can cause Guillain-Barré. Pain is most common in these patients and worse at night. And obviously the most severe complication is going to be respiratory failure. And are they going to initially come into us with that? No, they're going to initially come in with symptoms that are lower down. It's going to work its way up the body. So it's really important, if they're thinking this patient might have Guillain-Barré or they're ruling out other things, right? which happens in a lot of these things. If the patient is saying, I'm having numbness and tingling, and it was in my calves, and now it's up to my thighs, we have to really be on that and notifying that healthcare provider so that we know that we're getting closer to the step that it could affect their diaphragm and ultimately their respiratory status, and they would have to be put on a ventilator. Treatment in these patients, IV immunoglobulins, proper nutrition, and plasmapheresis. Ultimately, if it progresses up to the respiratory status, they're going to look like a spinal cord injury patient. And you're going to have to think about all those different body systems that could be affected and how our nursing care would need to, how would we take care of these patients. Some complications with these patients, because if we are to the point where this patient needs to be intubated, they're going to be less mobile. So they're going to be at risk for developing clots like DVT or PE, right? They could be at risk for having an ileus. They could have skin breakdown. Again, reflective of what we already talked about in spinal cord injury. If somebody is intubated, they are more at risk for infections, right? So what's our first sign of infection? Fever. So we have to be watching for fevers. We have to do meticulous suctioning, meticulous mouth care so that they're not at risk for ventilator-associated pneumonia. Patients aren't going to potentially be able to eat at this time, so they might need to have a tube feeding to help maintain their nutritional status. So they might need a G-tube. They might need TPN. Watching their albumin, their protein levels, watching their weight. Those are all important things that we're evaluating in their nutritional status, looking at calorie counts. Communication is going to be an issue with these patients, especially if they're intubated. So always talking to them, even though you don't think they can hear you, is going to be important. Urinary retention, again, could be a problem, so they're either going to need to be straight capped or a catheter left in them. Bowel programs might need to be also performed on these patients. Again, very similar to things we already talked about. New to this edition is something called CIDP, which is chronic inflammatory demyelinating polyneuropathy. Okay. Again, it's a rare autoimmune disorder. You can see the stats there. It's prevalence of 1.5 to 3.6 in a million people. So not a high statistic there of seeing these patients. This is new information to me, honestly. When I read this book, I wasn't familiar with this terminology, so I had to do a little bit of studying on this also. Very similar, though, to, obviously, Guillain-Barré, but the difference here, how you differentiate these two things, is that the symptoms gradually occur over 8 weeks, and there's not an acute onset. So in Guillain-Barré, we have an acute onset. Like I said, back with Guillain-Barré, they're not going to walk in, typically, with respiratory failure. However, if they've been sitting at home not knowing what's going on and not wanting to get medical care, maybe they will. Maybe they've had this numbness and tingling, they're just not sure what's going on, they don't want to come in to get it checked out. So I guess I shouldn't say they couldn't come in that, but if we started from the onset of somebody in acute Guillain-Barré, it's going to progress from bottom to top and in a more acute manner. Versus this CIDP, where it's going to take weeks to months. So 8 weeks would be 2 months. It's going to be a more gradual onset. The other difference is it is not self-limiting, meaning there's not really an end to that acute phase. These patients might actually progress to a wheelchair. They might have long-term damage that never resolves. Unlike Guillain-Barré, and we didn't mention that, these patients can recover from Guillain-Barré, okay? So they can, and it takes time because what's happening is the myelin sheath has to regenerate itself. And once that's regenerated, you're going to see these patients get better. It takes time compared to the CIDP patients that don't necessarily recover and have that improvement like we see in somebody with Guillain-Barré. Cause of CIDP, the book says, is unclear. It is considered autoimmune, could be associated with hepatitis C, HIV infections. You can see the list there, diabetes. lymphoma. Again, not something you're going to see or hear a lot about. Treatment, corticosteroids, we're right back to that. Immunoglobulins, plasmapheresis, where they're basically exchanging that plasma, cleansing those toxins within them. Chemotherapy is another option, and then immunosuppressive agents. And then finally, to wrap up the chapter, the book talks about tetanus and botulism. Just to keep it kind of short and sweet, tetanus can affect spinal and cranial nerves. It is caused by that Clostridium tetani, and that's found in spores it's caused by spores found in soil, garden mold. It could enter commonly through a wound. Someone steps on a nail, a rusty nail. It could be a dental infection, though. It could be somebody who's an IV drug user. It could be from a burn. So there's lots of different ways, but most commonly we think about somebody stepping on something or having an open wound that in an area that's not clean. So tetanus can cause someone to have a stiff jaw, stiff neck. They can have very rigid neck muscles, back, abdomen muscles can become rigid, and if not treated, convulsions can occur. Basically, this patient needs a tetanus injection. Tetanus shots are good for 10 years. If someone, though, has had an open wound or they stepped on something, if they haven't had a tetanus shot in 5 years, they should call their physician. They might have them come in for a booster if we're going on the 10-year mark. If for some reason somebody would develop spasms from this because it has been left untreated, then we're looking at IV medication that's going to help with these convulsions and spasms, such as Valium, morphine, some kind of heavy hitters there to help with that. But that's going to be few and far between that you see that. We commonly hear of getting a tetanus shot, right? And that's what we're going to encourage our patients to stay up to date on that. Botulism is rare, but it is the most serious type of food poisoning. It obviously deals with the GI system. Again, it's an organism found in soil or spores, and it's most commonly that we hear about it is dealing with improper canning within the home. Patients will typically complain of nausea, vomiting, diarrhea, abdominal cramping. If left untreated and not diagnosed, then they could have some neurological symptoms with that. And with this, they have descending flaccid paralysis that could occur. They could complain of blurred vision. They could have sore throat, difficulty swallowing, kind of a wide array of things, leading up to seizures and respiratory weakness, respiratory or cardiac arrest. So that would be the worst case scenario. Typically, we hear about it when it's just the nausea, vomiting, diarrhea. Patient goes to the physician. If for some reason this is diagnosed as true botulism, that is a reportable disease that has to be reported and looked into, because it could happen if somebody goes out to eat and they get food poisoning. So that is something that has to be tracked and reported. Diagnoses-wise with botulism, they're going to do some blood tests and maybe some other tests just to rule out other things that could be occurring. But again, we're looking at the patient's history, the patient's signs and symptoms, and then they come up with botulism. Treatment-wise, we need to cleanse that GI system. And we're going to do this by giving non-magnesium containing laxatives. Reasoning for that is magnesium worsens that toxin that we're dealing with. So we want to stay away from laxatives that contain magnesium. So we could do things such as enemas, tap water enema, soap suds enema. They could do lavages. We could use suppositories, anything like that to help cleanse that system. We wouldn't want to use things such as mag citrate or something that, again, has magnesium in it, because that's going to make our situation worse. And if worst case scenario, this patient ends up not getting treated and they have the descending paralysis that goes along with this, we're right back to treating this patient like somebody who has Guillain-Barré or somebody who has spinal cord injury. Okay, so we're not going to go back over that. Those things we've already discussed. So that wraps up this chapter on peripheral nerve problems. And we probably won't touch base on these things in class, so please listen to this, read your chapters, and if you have questions, don't hesitate to shoot me an email or ask me in class. Thanks.